Thank you in advance for your time this evening, and thanks, Dr. Hassan, for this opportunity. Today, we will be going over different kinds of luting agents, and we will go over the cementation procedures step by step. And towards the end of the presentation, you will have a chance to answer a few poll questions, which will help us do a quick review of the topics covered in this presentation. Luting agents, cementation procedures. Luting agents are used to ensure the stability of fixed prostheses throughout their lifespan. They can be either interim luting agents or definitive luting agents. Interim cementation. As we go over the interim cementation, you will see that there are advantages and disadvantages. The main advantage for cementing a restoration on an interim basis is that the patient and dentist can assess its appearance and function over a time longer than during a single visit. As for disadvantages, removing the restoration for definitive cementation may be difficult, even when temporary zinc oxide eugenol cement is used. To avoid this problem, the interim cement can be mixed with a little petrolatum, should be applied only to the margins of the restoration to allow subsequent removal without difficulty. If removing an interim cemented fixed dental prosthesis is difficult, the use of a crown removal device is recommended. Another disadvantage is that an interim cemented restoration may come loose during function. If the patient does not return for cementation, caries can develop very rapidly. To avoid this problem, interim cementation should not be undertaken unless the patient is given clear instructions about the objectives of the procedure, the intended duration of the trial cementation, and the importance of returning promptly if an abutment loosens. Definitive cementation. The choice of luting agent depends first on whether a conventional casting or an adhesively bonded restoration is to be cemented. Water-based dental cements, like conventional casting, or adhesive resins, like ceramic inlay, resin bonding, partial dentures. Now, moving forward, we need to understand that there are a number of requirements needed for an ideal luting agent. Those would be biocompatibility, retention, mechanical properties, marginal seal, low film thickness, radio opacity, ease of use, and aesthetics. The following are different types of dental cements, and we will go over each and every one in more details in the coming few slides. So the dental cements that we're gonna cover are zinc phosphate cement, zinc polycarboxylate cement, glass ionomer cement, zinc oxide eugenol, resin luting agents, and resin modified glass ionomer luting agents. Zinc phosphate cement. It's used for cast restorations, has adequate strength, has a film layer thickness of approximately 25 micrometer, has a reasonable working time around 5 minutes. Excess material can be easily removed. It has toxic effects, phosphoric acid, if used too close to the pulp. Incremental mixing is necessary because exothermic heat can cause the mix to set too rapidly. Crown cemented with zinc phosphate displayed increased resistance to dislodgement on preparations that lack resistance form. It's an excellent choice for luting restorations on otherwise normal, conservatively prepared teeth. Zinc polycarboxylate cement. It has relative biocompatibility. Polyacrylic acid molecule is large and therefore does not penetrate into the dentinal tubule. It has high viscosity, that means it's difficult to mix. The working time of polycarboxylate is much shorter than that of zinc phosphate. It's around 2.5 minutes. Residual zinc polycarboxylate is more difficult to remove. Less crown retention than zinc phosphate. It's contraindicated when cementing implant crowns on titanium abutments, chemical interaction with titanium. Its selection, therefore, should probably be limited to restorations with good retention and resistant form, for which minimum pulp irritation is desired, for example, in children with large pulp channels. Glass ionomer cement. It adheres to enamel and dentin. It has good biocompatibility. It may have an anti-cryogenic effect. It can release fluoride. It's translucent. It has superior mechanical properties. It's susceptible to moisture contamination during sitting, which leads to erosion if it wasn't protected. Post-treatment sensitivity can be a result of desiccation or bacterial contamination. It sits more rapidly than does zinc phosphate cement and it's easily mixed. Zinc oxide eugenol, it's extremely biocompatible, provides an excellent seal, but its physical properties are generally inferior to those of other cements, which limits its use. Resin modified glass ionomer. It was introduced in the 90s and became the most popular luting agent for all ceramic and laboratory process composite restorations. Combines some of the desirable properties of glass ionomer. For example, it can release fluoride and it has good adhesion, with the higher retention strength and low solubility of resins. Less susceptible to early moisture exposure, reduced post-cementation sensitivity, has higher strength and low rates of micro-leakage. Resin luting agents. These can be categorized on the basis of polymerization method, chemical polymerization, light polymerization, or dual polymerization. Composite resin cements with greatly improved properties were developed for resin bonding processes. They have adhesive properties. For example, they are capable of bonding chemically to dentin. Lack of solubility, less biocompatible than cement. The self-adhesive resins have been shown to have the lowest incidence of post-cementation sensitivity. Patients appear to experience the lowest incidence of post-treatment sensitivity with self-etched resin cements. Now, if we need to identify the ideal luting agent, the following is a criteria we should keep in mind. It should have a long working time, adheres well to both tooth structure and restorative materials, provides a good seal, non-toxic to the pulp, has adequate strength properties, compressible into thin layers, low viscosity and solubility, exhibits good working and sitting characteristics. Any excess can be easily removed. Unfortunately, no such product exists. The following reference table provides details on the indications and contraindications to luting agents types. As you can see, with different types of restoration, we can reference the indicated and contraindicated luting agents with each related chief advantages, chief concerns, and different precautions to take, which should help us decide the best luting agents to be used. Another reference table shows the mechanical properties of each type of luting agents. Now moving to the practical part of this subject, we have the restoration and tooth surface preparation. The restoration and tooth must be carefully cleaned and dried after the evaluation procedure. For the preparation of the restoration, cast restorations are best prepared by airborne particle abrasion of the fitting surface with 50 micrometer aluminum particles, which has increased the in vitro retention of castings by 64%. We can also use steam cleaning, use of ultrasonic units, or the use of organic solvents. As for the tooth surface, the area of cementation must be isolated. The tooth must be cleaned and dried. The tooth should never be excessively desiccated. Over-drying the prepared tooth leads to postoperative sensitivity. If a non-adhesive cement, for example like zinc, phosphate, or glass ionomer, is to be used, the tooth should be cleaned, gently dried, and coated with cavity varnish or dentin bonding resin. In this section, we will dig into a more detailed view of the cementation procedure. So cementation procedure step by step. Step 1. Remove any interim luting agent with a pumice wash or hydrogen peroxide. A eugenol-free interim luting agent should be used with the resin cements because eugenol inhibits the polymerization of the resin. Cast metal restorations should be airborne particle abraded, steam cleaned or cleaned ultrasonically and washed with alcohol. Step 2. Isolate the area with cotton rolls and place the saliva evacuator. On occasion, a rubber dam can be used. Step 3. Dispense the cement into the clean internal surface of the restoration. Step 4. Dry the tooth again with a light blast of air and push the restoration into place. The final seating of posterior restoration is achieved by rocking with an orange wood stick until all excess cement has escaped. Step 5. Check the margins to verify that the restoration is fully in place. When it's fully set, remove excess cement with an explorer. Dental floss with a small knock end. It can be used to remove any irritating residual cement interproximally and from the gingival sulcus. Step 7. Cements take at least 24 hours to develop their final strength. Therefore, the patient should be cautioned to chew carefully for a day or two. On the other hand, for the ceramic veneers and inlays, these restorations rely on resin bonding for retention and strength. The cementation steps are crucial for the restoration's success. Careless handling of the resin luting agent may adversely affect their longevity. Now for bonding. Bonding is achieved with the following main steps. Etching the fitting surface of the ceramic with hydrofluoric acid, applying a silane coupling agent to the ceramic material, etching the enamel with phosphoric acid, applying a resin bonding agent to etch enamel and silane, seating the restoration with a composite resin luting agent. In this figure, we can see a schematic of resin bonding technique. First layer is the ceramic surface. It's etched and silanated. Next comes the unfilled resin, followed by the resin luting agents and another layer of unfilled resin. Finally, layer D, which is the etched enamel. Now for a step-by-step overview of the bonding procedure. Step 1. Remove any interim restorations and clean the teeth with pumice and water or chlorhexidine preparation. A luting agent that contains zinc oxide eugenol should be avoided for cementing interim restorations before resin bonding inhibits the polymerization of the resin. The eugenol inhibits the polymerization of the resin. Cleansing with pumice leaves zinc oxide eugenol residue mixed with pumice, which can inhibit bonding. Etching with 37% phosphoric acid after cleaning with pumice may be the best way to remove zinc oxide eugenol. Step 2. Evaluate the restorations with glycerin or a dry-in paste. Verify fit, shape, and the insertion sequence. Step 3. Clean the restorations thoroughly in water with ultrasonic agitation. Dry the restorations. Step 4. Etch and silanate the restorations. Step 5. Isolate the adjacent teeth with matrix bands. Acid etch the enamel. 37% phosphoric acid is generally used and is applied for 20 seconds. Rinse thoroughly and dry. Step 6. Apply a thin layer of bonding resin to the preparation. Do not polymerize this layer because it might interfere with complete seating. Step 7. Apply composite resin luting agent to the restoration. Be especially careful to avoid trapping air. Step 8. Position the restoration gently, removing excess luting agents with an instrument or a microbrush. Step 9. Hold the restoration in place while briefly pat polymerization the resin. Do not press on the center of veneers, they may flex and break. Use dental tape to remove resin flash from the interproximal margins. Step 11. Complete the polymerization of the luting agent. Do not under-polymerize the resin cement. Allow at least 40 seconds for each area. Remove resin flash with a scalpel, sharp correct, or finishing tungsten carbide burr. Finish facial margins with a polishing cup. Finish the lingual margins with a finishing tungsten carbide burr. Use diamond and aluminum oxide finishing strips to finish and polish the interproximal margins. The completed restorations and the patient's new smile can be seen. Thank you everyone for your time and attention. Now let's move to the poll questions. Please take a few minutes to answer these questions and we'll discuss them in a bit.
Thank you, everyone. Thank you, Noor. So you're gonna share the questions right now?
Yes, I think Fatima has the poll questions.
Yes, Noor, if you check on the bottom where it says poll,
Yes, yes.
you can start.
Okay.
So all the respondents should be able to see the poll on the screen. Please go ahead and make your, oh, you did, you should be able to make your choices. Okay.
So, guys, pardon my ignorance, but I can only see 2 questions. Is that correct, Fatima?
No, you have to scroll
Actually
the
be able to
screen.
see 10 different questions. Are you
Uh,
not able to answer them?
I think I am, but I only see only the question 2 and then submit.
So the first question is, all of the following are definitive cements except?
No, I understand, but there's 2 questions on the polls when I pull the poll. And,
Dr. Hassan, just scroll. When you scroll, it'll show you the rest of the questions.
oh, I am scrolling, my dear.
Not working?
But it's not, I don't know why it's not. It's okay. I mean, we'll talk as long as everybody, if everybody has any difficulty, please let me know. Or let Fatima know, I guess.
Yeah, is anybody else having difficulty filling out the poll questions? Perfect. So you can see the results coming in to the poll. Dr. Tamim, you can review the answers once it looks like most of them have voted.
Yes, I can see the results. But
Can you
we'll get
see
them.
the? It looks like 6 of 36 have voted.
Yes.
So it looks
If you're
like me.
having issues with it, if you put your cursor over the actual poll and then scroll down, that might help.
Yeah, because I can see many of them has answered the 10 of the questions.
Yeah. But some another person told me that they can only see 2 questions. So I think if you put your cursor over the actual poll and then scroll down, it should. Aman, can you see the rest of the, can you see other questions? Is it working for you now? Awesome. All right, so we've got 19 responses. Do you want to give it one more minute, Noor, and then you can review it?
Yeah, sure. We'll give it a couple of minutes.
If anybody's still working through that poll, if you could just on the bottom, raise your hand so we know to wait for you. Looks like we're good, Noor. There's 26 respondents and nobody's responding to me.
Okay. So you have to end the poll.
You can go ahead and end the poll in the bottom right.
Yeah. Okay. I'm going to share the results with you.
Yeah, so now you can go ahead and share those results.
So for the first question, all of the following are definitive cements except, so it's obvious that we got it 93% that got it right. It's zinc oxide usual. It's interim cement. For the second question, what's an ideal luting agent? So this is a tricky question. I put it because just to focus on the one point that there is no such ideal luting agent. There's no luting agent that has all the desirable properties at the same time. So it's none of the above. An ideal luting agent should be compressible into thin layers. So the third option. The fourth question, a luting agent that contains zinc oxide eugenol should be best cleaned by, it should be cleaned by all of the following, but the most important one is the pumice and water, because the pumice and water will leave zinc oxide eugenol residue mixed with pumice, because the zinc oxide eugenol inhibits the polymerization of the resin. Now the fifth question, cement with best mechanical properties. So it's zinc phosphate cement compared to zinc polycarboxylate and zinc oxide eugenol. Zinc phosphate cement has the best mechanical properties among these three. The sixth question, cement that has large acid molecule, it's zinc polycarboxylate cement, because it has the polyacrylic acid molecule. It's large and therefore it does not penetrate into the dental tubule, which will cause the post-cementation sensitivity. So the post-cementation sensitivity is less with the polycarboxylate cement. Question 7. When comparing resin-modified glass ionomer luting agent to traditional GIC, so resin-modified glass ionomer is less susceptible to early moisture exposure. Question 8. The main property of resin luting agents is that it's capable of bonding chemically to dentin. I think the majority, like 43, got it wrong. They said low post-cementation sensitivity. No, it has high post-cementation sensitivity compared to the traditional cements. Question 9. Mechanical properties of glass ionomer cement are inferior to zinc phosphate or polycarboxylate. It's actually superior to both of them. Glass ionomer is superior, and it became more popular in the 90s. The last question is, when considering glass ionomer cement, what limitation should we be aware of? That it's susceptible to moisture contamination, so it should be protected with a varnish. Yeah, that's it.
Thank you very much, Dr. Noor. That was a very interesting presentation, and I really think you've done a great job with the questions. That was actually amazing, and you know what? I think it's the right thing to do. I do feel as well, you know, that going forward, this is just the way that we are going to be do it. And I do believe that this is our first time. Even I'm one of the guys that probably didn't know how to navigate through the system, through the poll system. So if you haven't, please don't feel guilty. I have earlier on sent you through the day the topic of our next lecture, and I mean just for this time we usually meet every 2 weeks, but just for this time, I believe Fatima has reached out to me, and she has said that. Some of you have mentioned to her that it might be Eid in our next Wednesday or the day before Eid. So they suggested to postpone it until the 19th of May. So our next meeting is going to be the 19th of May, where we are going to be discussing the our beautiful RCDSO lecture about the guidelines of the role of the opioids and in the management of acute and chronic pain. And it's such a beautiful one. So we're going to have to pick on somebody to present this topic. So am I going to have any volunteers, or shall I?
Actually, Dr. Hassan,
Yes.
Dr. Hussein Ghazi is doing that. He's already been volunteered.
So Dr. Hussein Ghazi, is he today among the attendees?
Not sure. Give me a moment. No, but he is aware and he's already preparing it.
Preparing it. Okay, perfect. So I mean that's I think how it's going to be. I think um, I don't know if Fatima has any other things to mention to them. I think if we are going to be as well writing, Fatima, I'm going to announce as well Dr. Misho's lecture for only our associates. Our associates, I believe, are going to get this lecture free of charge. There will be no fees for our associates. Uh, it will be done, I believe, on the 30th of May, and it will have 2 hours of continuing education, certified. And for you who don't know, Dr. Misho is a certified prosthodontist who had previously came and lectured with us, and he did a great presentation about veneers. And I believe he is the head of the Prosto in Dalhousie University. It's a very great, talented person, a very pleasant person, and his way of teaching is actually phenomenal. I'm going to urge all of you to attend the lecture. And do you have anything else to tell us, Fatima, about it?
Sorry. No, I actually really like his presentation style. He's great.
All right. The only
And
thing is
he
the 9
did register a few different courses. I've also uploaded some Core 1 courses for us that are going to be presented by the PLP.
Mhm.
I will share those to our group later on.
All right, wonderful. Thank you. Thank you for all your hard work, Fatima. And it's very exciting that we've obtained the status to issue a Category 1 courses. That's actually is a great news. Thank you very much, Fatima, for everything that you're doing for us. And does anybody has any questions for Dr. Noor, by the way, about today's lecture? As
Yes, I think
usual,
there's one question.
okay. You want to read it?
Uh,
And
yes, if the mixture of pumice and zinc oxide fusional inhibits binding of resins, wouldn't acid etch be best to clean zinc oxide? So yes, actually the etching with the phosphoric acid will be the last step after cleaning with pumice and water, and then we rinse, and then we do final etching with the phosphate with the 37 phosphate acid, and then we rinse again, and then the tooth is ready to be cemented.